morning. My name is Gulrez Mahmood. I'm a third-year medical student at Wayne State, and I will be presenting the therapeutic effects of sildenafil on blast-induced tinnitus and hearing loss. So when you hear the word blast, what typically comes to mind are improvised explosive devices in Baghdad and artillery strikes. However, in light of the recent events in Boston and Texas, it becomes apparent that this is not just a concern for military personnel, but civilians as well. So when a person is exposed to blast, they suffer from a very unique type of injury called traumatic brain injury, which is defined as neurotrauma from an external force. In recent wars in Afghanistan and Iraq, TBI has become the most prevalent type of injury sustained on the battlefield. As these veterans are returning home, they're presenting with symptoms of post-traumatic stress disorder, depression, as well as memory loss. But the most common complaint actually happens to be auditory dysfunction. Now, when a person is exposed to blast, there's three components to the injury. The primary neurotrauma is from the blast wave itself. As the wave moves past your head, it creates a contraction and expansion of air particles. And this results in a compressive as well as shear forces on the neural tissue. The secondary component involves shrapnel and debris that's flying around and causing penetrating head injury as well as blunt trauma. There's also a tertiary component because the brain is moved in its housing, which causes a coup and counter-coup type damage as well. However, despite this great graphic and despite our increased understanding of the mechanism behind TBI, there has yet to be a definitive therapeutic intervention for this population. So this prompted us to look at the science. We wanted to know what's happening at the cellular or the molecular level. And in my reading, I came to learn that at the heart of TBI is actually a chemical messenger known as nitric oxide. Nitric oxide is produced by a amino acid precursor from the actions of nitric oxide synthase. And there's three different isoforms of this enzyme, the neuronal, the inducible, and the endothelial nitric oxide synthase. Now, much of the framework for this investigation is actually derived from a paper that was a review article that was published in 2006 at the Baylor College of Medicine. Dr. Sherian was the primary author. And what these authors were looking at was the concentration of nitric oxide within the neural tissue as a time course after TBI. And what these authors suggested was that within the first 5 to 30 minutes after brain injury, there is an upregulation of nitric oxide. 90% of that NO is derived from the neuronal isoform, and 10% is derived from endothelial nitric oxide synthase. And that 10% is thought to have neuroprotective qualities. And so we asked the question, is there a pharmacological agent that we can use to manipulate this nitric oxide system to enhance the level of endothelial isoform? And that's where sildenafil comes in. There have been a number of studies that show that sildenafil specifically increases the expression of endothelial nitric oxide synthase. Secondly, the drug has a wide array of anti-apoptotic properties. It produces cardioprotection in the myocardial infarction model, as well as enhancing neurological recovery after ischemic and embolic stroke. And lastly, there was a recent article that was published in China in 2011 that showed that sildenafil protects against noise-induced hearing loss. So we have our drug, and we set out to do the experiment. So we split our animals into a couple of groups. The first group was our treatment group, received the blast, and after the blast, immediately after the blast, we gave them a drug dosage of 10 milligram per kilogram orally for 14 days. We also had an untreated group which received the blast but did not receive the drug, and a sham control which did not receive the blast but did receive the drug just to see if the drug itself had any side effects, and we found that it didn't. This is a diagram of the shock tube that we used to produce blast. This is at the Wayne State Department of Bioengineering. Just a brief overview of how this works. We insert a thin plastic sheet made out of mylar. This is a cousin of Kevlar, so it's a very tough plastic material. And in this driver chamber, which is at one end of the shock tube, we build up a bunch of pressure until that mylar membrane bursts. When that membrane bursts, it sends a powerful pressure wave through the shock tube that's concentrated at the very tip of it, and that's where our animal is harnessed. For this investigation, we used a very well-established model of tinnitus detection called the GAP model. And just a brief overview of how this works. In a normal healthy rat, when delivering a constant background noise followed by a loud sound, we see the animal expressing a startle force. However, if we insert a gap in that background noise, followed by the loud startle noise, the animal exhibits something called startle force suppression. However, if the animal is suffering from tinnitus, it's unable to detect that gap, and therefore, when we deliver the loud sound, it goes back to producing that startle force that we saw initially. And so in this investigation, we attempted to treat this tinnitus and mitigate a level of tinnitus using sildenafil so that the animal would go back to producing the suppression in the startle force. This is our gap data for the first 4 weeks following blast. The y-axis represents the ratio of the movement, so this is the startle force. And the x-axis represents the different frequencies that we tested. The red bars represent the untreated animals, and the blue bars are the treated group. It's easy to remember because the pill itself is blue, so we labeled the treatment animals blue. Now, as you can see in the first 2 weeks following blast, both the treatment and untreated group exhibit an elevation in startle force. This is indicative of the presence of tinnitus in both the groups that were exposed to blast. However, sildenafil appears to have a therapeutic effect because the blue bars, although they show elevation, are significantly less elevated than the comparative red bars, which represents the untreated group. Now, this therapeutic effect persists into the next 2 weeks as well. And as time moves on, we see tinnitus consolidate at the higher end frequencies for the untreated animals. And this is reflective of previously published data from our lab using blast-induced studies. For the next 4 weeks of our experiment, we saw the therapeutic effect of sildenafil continue on all the way until 6 weeks. And again, it's consolidated at the higher end frequencies, and that's where we see the most significant therapeutic effect. Keeping in mind that we stopped delivering the drug after 2 weeks, so whatever therapeutic effect we see in the next 4 weeks is an after effect of the drug therapy. This significant therapeutic effect becomes insignificant at the 6 to 8 week time frame. We also ran PPI testing, which is pre-pulse inhibition. This is sort of complementary to the GAP test, only it's more reflective of hearing impairment rather than tinnitus. And so in the first 2 weeks after blast, we actually see hearing impairment in both groups at every single frequency. Interestingly though, at every single frequency, we see a therapeutic effect of the drug because all of these bars show significantly higher hearing impairment in the untreated group. This is actually my favorite graph in the presentation because it shows a very robust therapeutic effect of the drug. And this therapeutic effect actually becomes insignificant in the 2 to 4 weeks after after the acute stages. And it remains insignificant for the duration of the investigation. So although we see the therapy in the initial stages, it's not as robust or long-lasting as our GAP data suggests for tinnitus. To complement our pre-pulse inhibition, we also tested for ABR thresholds. And according to our data, if you look at the graph, the black lines represent the sham group, which was not blasted. So at day 0 post-blast, we see a tremendous elevation in hearing thresholds in both groups, treated and untreated. Interestingly, this elevation in threshold reverses within 1 week, and it continues to reverse 3 weeks and 6 weeks. It's back down to what it was before the blast. Now, recently there have been some studies that suggest that even if the ABR thresholds are to return to normal, there could be some underlying changes that are not apparent on the ABR. And these underlying changes can represent a more chronic type of damage to auditory structures. So we went back to our ABR data and we measured the wave 1 amplitudes. And we found that the pre-blast level produced this kind of a pattern for wave 1 amplitudes. When we compare this to our 6-week post-blast data, we see that the graphs are completely different. If I can superimpose these graphs one on top of the other, it'll be a little bit easier to compare. We see clearly there's a difference in post-blast compared to pre-blast, and this is at the 6-week time point. If you can remember from our ABR data, at 6 weeks, our hearing thresholds had returned to normal. So we see these underlying changes despite the fact that our thresholds had returned to normal. So in conclusion, we learned a couple of lessons in this investigation. The first is that there appears to be a robust therapeutic effect of sildenafil on tinnitus that lasts until 6 weeks. Secondly, this therapy is concentrated at the higher end frequencies because as time went on, that's where the tinnitus consolidated. Thirdly, there's strong evidence of protection from hearing impairment according to our pre-pulse emission data, at least in the acute stages. And lastly, the triple blast mechanism that we used in this study appears to have long-lasting effects in the wave 1 amplitude despite the return of ABR thresholds. In terms of the future directions of the study, what we want to do is maybe change the dosing regimen, maybe give a longer duration of the drug so that we can extend the therapeutic effect. And also we want to run immunohistochemical staining to verify that there's an enhanced expression of endothelial isoform of the nitric oxide synthase versus the other isoforms. And with that, I want to thank you for your time and look for any questions. Yes, Patricia.
So your hyperoxidizing is going through blood vessels?
Yes. Yeah, this was an oral dose. We're assuming that it affects the neural tissue going through the blood.
The interesting thing about sildenafil is how potent it is. No matter whether you say it is toxic or inhibitory, at 12 nanomolar, you get effects. And so when the pharmaceutical companies really worked to make this very effective. Now, what does it really do? What it does is whenever you have these specific phosphodiaphrases, it's going to enhance the level, the inhibitor is going to enhance the level of cyclic GMP. So wherever you have, whatever tissue, there are a lot of studies out there on effects of sildenafil in different tissues. So the basic thing to remember, I think, is really that what you're seeing, if you've got the right PDE forms there, is that you're going to be seeing an elevation of cyclic GMP, and whatever that elevation does at that site.
That's great.
So I have a couple questions. Firstly, it's a little bit counterintuitive to choose it because sildenafil also is important to cost. So
Yes, it is.
you comment on that.
Yes, I
And
can.
then the second question was, I didn't recall whether you said it was given pre-blast or at the time of the blast. So can you
Yes.
pre-condition animals if you start giving it 2 weeks before?
Okay.
Then my third question is, what makes the endothelial form isoform protective as compared to the other isoforms? Can you selectively knock down the endothelial isoform in these animals and repeat it?
Okay. So the first question is, why did we pick sildenafil even though it's been reported to show hearing loss? And my response to that is that all of those concerns are mostly based on self-reported patients. It's not based on audiometric analysis. And secondly, the hearing loss that's reported in those as a side effect is usually unilateral. If it was truly a side effect of the drug, it would be bilateral mostly, I feel. And lastly, the population that's reporting these hearing changes in response to tinnitus happens to be an older population in which hearing or auditory dysfunction might just be prevalent in general. So that's why we decided to go ahead and go with sildenafil for this investigation. Secondly, Dr. Smith asked, did we precondition or did we deliver the drug afterwards? In this investigation, we actually delivered the drug after, immediately after, within the first 5 minutes after the final blast. And this actually goes along with our thinking because the paper that I had mentioned earlier talks about the changes in nitric oxide that follow traumatic brain injury, not necessarily before. It's possible that if we precondition the rats, we might get some different data, but we decided to go with the model that we had derived most of our framework from, which was after blast injury. And lastly, you asked what makes the endothelial nitric oxide synthase responsible for the therapeutic effect. And there's been a number of articles that suggest that it's actually the endothelial isoform that activates the different anti-apoptotic pathways that we feel are responsible for this therapeutic effect. And one of those is the AKT pathway. So, yeah.
Can you conjecture or guess whether a transtympanic injection of sildenafil would have a higher or better effect or longer lasting effect than what you're seeing with the oral dose?
Transtympanic
injection through the eardrum.
It's possible that because because we're delivering the drug orally and we're trying to have the effect within the first 5 minutes after blast, it's possible that if we inject the drug right to the site where it needs to be, that we have even longer lasting effect. Definitely, I would assume so, actually.